Good evening to everyone in the UAE and good morning to all in the US. Thanks for joining the 12th term award winners webinar series organized by the Sheikh Hamdan bin Rashid Al Maktoum Award for Medical Sciences. Established in 1999, this award has been a driving force funding distinctive research in academia and honoring excellence in the service of the healthcare. Undoubtedly, these efforts have really paid off well, as two of the Grand Hamdan Award winners have gone on to getting the Nobel Prize, namely Sir Robert Edwards and Dr. Harvey Alter in Physiology 2010 and 2020, respectively. Dissemination of knowledge in the field of medical sciences is one of the leading objectives of the award, with the aim to provide opportunities for capacity building and inspire people towards excellence. Hence, this new webinar series will be presented by the winners of the award. The theme of the award for the last cycle was infectious diseases and their prevention, immunity, and therapy. With this background, it gives me immense pleasure to introduce Dr. David Ho, the 12th term winner of the Hamdan Award for Medical Sciences in the field of immunity. Dr. Ho is the founding director of the Aaron Diamond AIDS Research Center and the Clyde 56 and Helen Wu Professor at Columbia University. Dr. Ho grew up in California, in Los Angeles primarily, and graduated in 1974 with the Bachelor of Science majoring in Biology and Physics from the California Institute of Technology, which was followed by an MD degree from the Harvard Medical School in 1978. It was during his internal medicine residency at the Cedar Sinai Medical Center, Dr. Ho first encountered a patient with the symptoms of a mysterious illness at that point in time, which later to be known as the AIDS caused by HIV. If I could say, Dr. Ho's biggest contribution to AIDS is the management of HIV replication through the use of antiretroviral therapy, which later came to known as HAART, which has resulted in saving millions of lives globally. In recognition for his contribution to fight against HIV and AIDS, Dr. Ho was named the Times Person of the Year in 1996. Since then, he has received many awards, which includes such as the Presidential Citizens Medal from President Bill Clinton, also the induction into the California Hall of Fame, and the National Leadership Recognition Award from the National AIDS Memorial. Currently, over the years, Dr. Ho has published more than 400 publications with a current H-index of 131 and more than 68,000 citations. Since the COVID-19, Dr. Ho has been leading the coordinated response to combat the pandemic at Columbia University. The focus of his current research is directed towards understanding the clinical aspects of COVID-19 and rapidly identifying new drugs to treat and prevent the disease. Please join me in welcoming Dr. Ho, who is going to be sharing with us his latest work dealing with the antibody evasion of SARS-CoV-2 variants. After Dr. Ho's presentation, we will take questions from the audience. So please type your questions into the Q&A box during the talk so that he can address them. Dr. Ho, the floor is yours now. Please go ahead.
Thank you very much, Professor Rizvi, for that wonderful introduction. Good evening and good day to everyone on this webinar. Let me share my slides, and could you see them?
Yes, we can see them.
Okay. Again, thank you very much. As Professor just mentioned, I have worked on HIV/AIDS for much of my career. However, when the COVID-19 pandemic broke out, we shifted our attention to work on SARS-CoV-2. In particular, we tried to understand how antibodies attack this virus, and then how this virus in turn tries to evade the immune system. So that's what I will focus my presentation on today. Let me begin with a few introductory slides, which I'm sure you are all well aware of. The COVID-19 pandemic has raged on for the past 3 years with devastating human and economic tolls. We have suffered waves after waves of infection, and the confirmed case number is worldwide is about 676 million, with almost 7 million deaths. In the US, there have been at least 103 million confirmed infections with over 1 million deaths. And based on what I understand, UAE has suffered about 1 million confirmed infections with over 2,000 deaths. Now, of course, these are underestimates because they're based on confirmed cases. And indeed, there are several surveys that suggest maybe up to 80% of the world's population have been infected already. Of course, and before I move on, I should say that it seems that the pandemic has waned, although we are still seeing a fair number of infections, but those infections have not resulted in as many hospitalizations and deaths. So it appears the pandemic is now waning, and but the fact that it's now under control is really due to the unprecedented response over the past few years in terms of scientific and technological advances, with the scientists and engineers and other folks coming together to work collaboratively with great speed and efficiency. And of course, we have witnessed in many places unprecedented political will and resource provision to fight this pandemic. Likewise, there's been unprecedented commitment from regulators, particularly in the US and in Europe, to facilitate drug and vaccine development. And this has resulted in vaccines, therapeutic antibodies, and drug being developed, tested, and authorized for use all within 1 year or less. And now we actually have this new realization that we have a new paradigm, that medical breakthroughs could be achieved without the usual protracted timeline. Let me just say a few words about vaccines, which I'm sure you're well aware of. These were, as mentioned earlier, developed in record time. And basically, today we have 4 platform technologies to apply the vaccines. mRNA vaccines exemplified by those made by Pfizer, BioNTech, and Moderna. Viral vector vaccines made by Johnson & Johnson and AstraZeneca. Inactivated vaccines made by 2 companies in China. And then the nanoparticle vaccine by Novavax in the US. And as you could see here, in terms of efficacy against symptomatic infection, the mRNA and the particle vaccines have about 90% efficacy, whereas those based on viral vectors and inactivated vaccines have somewhat lower protection. But all of them have fairly robust protection against severe disease and death. And of course, these vaccines all were designed and implemented to target the spike protein on the surface of the causative agent SARS-CoV-2. Spike shown here. And when one looks at the structure in detail, and the structure was determined early in 2020 by Jason McClellan in Texas. And you could see that the spike is actually comprised of 3 identical units coming together to form a single trimer, as shown here. And there are critical domains such as the receptor binding domain shown in the red here, which pops up to engage the cellular receptor ACE2, which is largely expressed in human airways. And then there's another domain also near the top of the spike called the N-terminal domain, or NTD, whereas the receptor binding domain is called RBD for short. And in fact, the RBD has to flip up from its down position in order to engage this receptor ACE2 as demonstrated here. And the scientists in the field have in detail characterized the antibody responses directed to the spike by isolating, I would say, several thousand monoclonal antibodies and characterizing them in detail. And here I provide a very gross summary of the antibodies that are directed to the RBD or the NTD. And as you could see, almost all the antibodies that are capable of neutralizing SARS-CoV-2 are directed to these two domains, with RBD constituting much of the neutralizing target, whereas NTD accounts for a small portion. And then when you look at it closely for the RBD, this is actually the inner face, this is the upper face, this is the inner face but lower down, and this is the outer face of the receptor binding domain. And antibodies have been targeted to these regions, and they're classified as class 1, 2, 3, and 4. And what's shown in these color lines are the footprints of various monoclonal antibodies directed to different regions. On the N-terminal domain, most of the antibodies are directed to this pink region. And it turns out that all these antibodies that target these 5 regions are, in essence, blocking ACE2 binding. The mechanism for virus neutralization of these antibodies is not yet known. So in short, this ACE2 binding inhibition is the major mechanism for antibody neutralization of SARS-CoV-2. As depicted here, RBD needs to bind ACE2. If an antibody binds to RBD, it interferes with receptor binding and hence inhibition of infection. In addition to vaccines that target the spike, there have been many monoclonal antibodies that have been isolated and characterized and manufactured and developed as therapeutics against SARS-CoV-2. And these companies listed here have come up with antibodies that are capable of neutralizing SARS-CoV-2. They go by various names shown here. With the exception of the AstraZeneca antibodies, all the other ones have been shown to be therapeutically useful in reducing hospitalization and mortality if given as therapies. And then the AstraZeneca antibodies have been given prophylactically to prevent infection, particularly in those individuals who cannot respond to vaccines. So the antibodies were generated against the spike, and all these antibodies listed here target the RBD class 1, 2, or 3 region. But as you know, with the evolution of SARS-CoV-2 variants, all of these antibodies that have been developed and authorized or approved have now been knocked out by variants that have emerged in the past 18 months. And of course, these variants also substantially lower vaccine efficacies from the 90% level down to a much, much lower level in terms of protection against symptomatic disease. Now, let me shift the attention to SARS-CoV-2 evolution and emergence of various variants of concern over the past 2-3 years. And you could see that much of 2020 was dominated by the original strain. And then by late 2020, the Alpha variant emerged in the UK and rapidly overtook the original strain. And there was some competition for a short while from variants shown in the blue and purple, which represent the Beta variant from South Africa and the Gamma variant from Brazil. But all of those were then rapidly replaced in the middle of 2021 by the Delta variant that emerged from India. And that dominated the rest of that year. And of course, we know in late 2021, the Omicron variant of concern emerged from Southern Africa and very rapidly replaced all the prior variants. And then the Omicron variants have continued to evolve into subvariants now known as BA1, BA2, BA4-5, and each successive subvariant overtook the prior ones. And BA5 was dominant by the end of 2022, but we recognize that additional subvariants that are derived from the previous Omicron viruses began to emerge and ultimately to dominate. So now if we look at more recent picture globally in the US or in the UK or the European region, as well as a couple of representative Asian countries shown here in Japan and Singapore. Over the last 4 or 5 months, you could see that the BA5 is now overtaken by these additional variants that have come about. And they are indeed largely XBB, XBB 1.5, BQ1, and BQ 1.1 shown in these colors here. And they constitute a large majority of the viruses that are circulating today. In Asia, the picture is slightly different in that BN1, which is a sublineage of Omicron, is actually quite prevalent. But you could also see that this salmon color variant is rising, and that's CH1.1. It's something that is a bit worrisome right now. Although I won't show you any data for CH1.1, I would just tell you that the results are pretty much the same as XBB 1.5. So over the past 2 years, my team has been busy characterizing all of these variants, trying to answer why we have this pattern of evolving dominance by successive variants or subvariants of the virus. Is it because the later variants are more transmissible, or are they more evasive to antibodies? And as you will see from the data, the major answer is that the newer variants, the dominant variants, are much more evasive to antibodies that exist in our serum. So here's a summary of the data that our group has generated to measure the affinity of the spike of these different variants in their binding to the ACE2. And this is done by what we call surface plasmon resonance. And what we did is to generate the spike protein for each one of these Omicron subvariant along with the original variant and determine the binding affinity as measured on the y-axis. And here the lower bars represent higher binding affinity compared to the original strain. As you could see, all of these Omicron subvariants have higher affinity compared to the original strain. However, the recently dominating strains here are not necessarily of higher affinity than the earlier Omicron subvariants, suggesting that in terms of binding affinity, they're about the same. However, when we look at evasion to serum antibodies, and in this case, sera from vaccinees who received 3 shots of mRNA vaccine, and look at fold change compared to the original strain, you could see the first Omicron variant BA1 is about 5-fold more resistant to serum antibody neutralization. BA2 is about the same. BA45 is about 2-fold more resistant than the original. But now when you get to the more recent variants, BQ and XBB, and I should say CH1.1, they are substantially more resistant compared to the original strain or to the earlier Omicron subvariants. So the recently dominating viruses are those that are most evasive to serum antibodies. Another way to look at the data from the last 2 slides is to plot the fold change in antibody evasion and fold change in receptor binding affinity, knowing that the BQ1, BQ1.1, XBB 1.5, these are the dominant viruses presently, and these are also the most evasive, even though in terms of receptor binding affinity, they are in the same range as those subvariants that have been overtaken. So this would suggest that antibody evasion is the primary driver for SARS-CoV-2 evolution right now. And because these variants are much more evasive to serum antibodies, we have roughly determined that vaccine efficacy has been greatly compromised by these variants. It is believed that the protection against infection against the newer variants has dropped to only about 30%. From about 90%, although importantly, protection against severe disease remains robust. So that is quite reassuring. At this point, you may ask, what does this mean now that we have a bivalent vaccine that's based on the BA5 subvariant? So that bivalent vaccine has one component that's BA5 and another component that is the original virus. And so we examined this particular issue by looking at 3 cohorts of individuals. All of them received the primary immunization, 2 shots, followed by a booster some 3 months later. And then after a period of 6 to 10 months, the first cohort received the same monovalent vaccine as an additional booster, whereas the second cohort received the bivalent vaccine as the second booster. And then the third cohort, instead of getting a booster, had indeed BA5 breakthrough infection. And so we looked at their antibody responses in serum at 1 month post these events, as well as 3 months post. And the results were generated by my postdoc, Cheng Wang. And you could see that at 1 month or at 3 months, the results against the original strain, BA2, BA5, BQ1.1, XBB 1.5. For the monovalent shown in blue, the bivalent shown in the pink, and the breakthrough, BA5 breakthrough shown in the olive color, you could see at 1 month, they were roughly similar And certainly there was no indication that the bivalent vaccine booster was superior. And then more recently, we looked at what happened after 3 months, and you could see, once again, comparing monovalent versus bivalent boosts, the results are roughly the same. Whereas for those with BA.5 breakthrough infection, the serum neutralizing titers were substantially higher. So the fact that we're not getting a higher neutralization with the bivalent boost that contains the BA.5 component, even against the BA.5, suggests immunological imprinting is at play. That is, our immune system already has been primed to see the original spike protein. And now when we present it with a different spike protein, it in a large way is ignoring the new antigen and is preferentially seeing the O antigen. So at this point, there's no evidence that the bivalent vaccine is superior. So let me come to the study of monoclonal antibodies, even though these antibodies are now largely knocked out by the latest variants. But here's a chart that will give you a pretty good image of how SARS-CoV-2 has evolved in different parts of its spike protein to evade antibodies. So here I have summarized the antibodies that are directed to other regions, to the NTD, to the RBD class 1, class 2, class 3, and class 4 antibodies. And then down here is the original strain, followed by alpha, beta, gamma, delta, and the Omicron subvariants. And you could see all of these antibodies were active against the original strain. And importantly, those that were authorized for clinical use are shown in green. So the others were investigational antibodies. And you could see with the emergence of the alpha variant from the UK, that knocked out NTD antibodies and a few of the class 1 monoclonals. And then when the beta variant emerged from South Africa, you could see NTD antibodies, class 1 antibodies, the same class 1 antibodies, and now they're class 2 antibodies that are knocked out. And very similar for gamma. And then delta was NTD, but instead of class 1, it was class 2 and class 3. But with Omicron, you see for the first time impairment of essentially all classes, with a few holes allowing certain monoclonals to get through and still neutralize the virus for the original BA1, BA2, and then BA5 begins to plug up some of those holes. And then with the recent BQ and XBB, it seems that all the holes within NTD, within RBD class 1, 2, 3, and 4 are plugged up. So the virus is simply adding more and more mutations to create a bigger and bigger shield against these antibodies. So one could, from this picture, and not shown here, we have mapped the individual mutations that confer the antibody resistance. And you could see it occurring mostly at the top of the spike, one after another, accumulating over this period of time. It is really viral evolution being well documented. Nevertheless, there are still a few holes that allow some antibodies to go through. And what I will tell you next is there's a hole here and there's a hole here that's not shown. And we only more recently recognized. So I think, our team and other teams are continuing to see if we could find effective antibodies that could act against the recent SARS-CoV-2 variants, because we need additional therapeutic agents. In addition, we need preventive interventions for millions of individuals who are immunocompromised and do not respond robustly to vaccines. And now I just want to share with you the identification and characterization of 3 human monoclonal antibodies that could neutralize all SARS-CoV-2 variants today, and 2 of them have novel mechanism of action. So here's the first one, which we call 1219. A postdoctoral colleague, Li Hong Liu, isolated from a patient. It was among over 100 antibodies that he isolated. 1219 is shown here. This is a sister antibody from the same individual, which, as you can see, both of these neutralize, as shown in the red, quite well. The viruses, all viruses we have tested in the SARS-CoV-2 family, including these latest variants, BQ1, BQ1.1, XBB, CH1, DS1, etc. The only virus it doesn't neutralize is the original SARS virus from 20 years ago. And that, of course, we know is a different virus in a different lineage of sarbecoviruses. In hamster experiments, prophylaxis experiments challenged with the Omicron BA1 virus, you could see that animals that received the control antibody shown in black, and those that received this monoclonal 1219 shown in purple, about 3 days after virus challenge, we see substantial reduction in viral load as measured by PCR in the nasal turbinate, in the lung, and then this is as determined by measuring infectious virus in the nasal turbinate and in lung. So in vivo, it's quite protective. When we looked at this antibody's ability to block ACE2 binding, it blocked quite nicely ACE2 binding. So having this result, we expected that this antibody would be binding to the receptor binding domain. However, when we saw the structure of the antibody bound to the spike protein by cryo-electron microscopy, as was done by Ryan Kasner, you see the antibody shown in the darker and lighter purple color. It is not binding to the top of the receptor of the RBD shown in green here. And on the side view in particular, you could see it's sandwiched below the RBD at binding to an element which we call SD1, which is right below RBD, and between NTD here, shown in the orange color. This is a close-up. You could see the heavy chain of the antibody binding to SD1 and partially to NTD, and the light chain binding to the NTD. So this naturally raised the question, if it's binding here and ACE2 is binding here, how is it blocking receptor binding? And that, after a considerable amount of work, that became clear as we did what's called a 3-dimensional variability analysis on the cryo-EM structure on those complexes that have 3 antibody fragments bound to the spike. And here's a video that shows you what's going on in this 3D analysis. And so you see this is the top view. You see the molecule breathing with 3 antibody segments bound to the spike between RBD and NTD. Here's the side view, and you could see that throughout the observation period, the RBD remains in the down position. So if RBD remains in the down position, it cannot bind the receptor, as I discussed earlier. Now, looking at, next slide. Now, in this next video, you see we're looking at same analysis, except we're looking at complexes with two antibody bound to each spike with one component unbound. And you could see that components that are bound by the antibody stay down, whereas the unbound component, the receptor binding domain, flips up. So we believe this antibody is locking the RBD in the down position, so the virus can no longer bind the receptor. And in a more detailed structural analysis, I would just summarize using this cartoon. When the antibody is sandwiched between SD1 and NTD, it sort of locks both of them in that conformation. As the NTD tries to move, it pushes the RBD and causing a downward clash with the antibody, as shown here. And then when the RBD tries to move up, it will cause a downward clash of the NTD with the antibody, shown here. And therefore, simply both elements cannot move. And we now have confirmed this locking down by loss of binding of class 1 RBD monoclonals, because these antibodies would only bind RBD in the up position. Importantly, the residues that constitute this epitope here are extremely well conserved among all SARS-CoV-2 viruses that have been sequenced to date. So this region has not been changing, and probably because this region normally is not under a great deal of antibody pressure. So it suggests that such antibodies are rare and they're not commonly made in infected individuals or vaccinated persons. So this antibody now joins the rather exclusive club of monoclonal antibodies that retain activity against all current variants. And this is a list out of thousands and thousands of antibodies that have been isolated and characterized. These are the few that retain activity against these latest variants. And now 1219 does so also. And if you look at this list, 1219 is actually closer to this antibody S3H3 that's targeting SD1 down here. Of course, 1219 is actually targeting to a region that's left of that here between NTD and SD1. But there are antibodies that penetrate through essentially class 1 RBD. Somehow the virus has not made the critical mutations to evade these 4 antibodies. Now, in the last couple minutes, I'll just tell you that another postdoc in the group, Sho Ikutani, has isolated a bunch more monoclonals, and I just want to tell you about 2 of them. One is 14.7, which is behaving like these antibodies here, targeting class 1, and 16.10, it's targeting this region. However, it has a very interesting novel mechanism of neutralization. So here's the slide that show you the 2 new monoclonal antibodies. So here's 14.7. As you could see, it neutralizes the original strain, alpha, beta, gamma, delta, and then earlier Omicron subvariants and later Omicron subvariants, although albeit with slightly lower potency. It doesn't hit SARS virus. It doesn't hit some of the viruses found in bats, but all SARS-CoV-2 are neutralized. And you could see from this cryo-EM structure, it's binding to the top and on the inner aspect. So it's actually RBD class 1 antibody that's somehow has managed to escape from the mutations. And we believe this antibody obviously would neutralize via inhibition of receptor binding. This antibody 1610 is not as potent, but it hits all the SARS-CoV-2 variants and Omicron subvariants. Again, not SARS and not some of the bad viruses. But in looking at the structure, every time one adds the antibody to the spike falls apart, giving a fallen apart structure of the RBD here, SD1 here, which is bound by the antibody and the NTD. So it appears that this antibody is capable of disassembling the spike. And that is of great scientific interest, even though this antibody, the potency is not so great. So in the more recent work, we have uncovered a couple of novel mechanisms for SARS-CoV-2 neutralization by antibodies. Of course, our newer antibody is the same as many monoclonals that have been developed and characterized, and it blocks by inhibiting receptor binding. Such antibodies are much more potent, much more common, but subject to evasion by the new variants. We found an antibody 1610 that's not as potent. It's probably quite rare, but retains breadth, and it disassembles the spike, and perhaps that's the mechanism for virus neutralization. And lastly, this antibody that I just described in some detail is neutralizing the virus by conformational locking, making the spike turn into a position that can no longer engage the receptor. And this antibody is moderately potent, but probably rare, which is good in terms of retaining breadth against variants. So I will, given the time, I will end here. I'm thankful to the Sheikh Hamdan Foundation for the honor and for the opportunity to present at this webinar. Thank you very much for your attention.
Thanks a lot, Dr. Ho, for enlightening us how SARS-CoV-2 variants evade the host immune response. I'm sure Dr. Ho's presentation has generated a lot of interest, and therefore we will take questions from the audience now. As mentioned earlier, the questions will be taken only in the written form. So please type your questions in the Q&A box if you have not already done so. So we have a few questions here, Dr. Ho. So let's start one by one. If I could, the very first question is, what are some of the current strategies being used to combat the antibody evasion properties of SARS-CoV-2 variants, and how effective they have been in preventing and treating COVID-19?
Well, in terms of therapeutic antibodies, I think people are looking for new ones. Obviously, if a person had not seen the prior variants or prior vaccines, they could generate a novel response. Let's say a young child who has not been infected or vaccinated, such a person would respond to a new vaccine that would protect against new variants. But that effort is easily said, but difficult to achieve in that we're constantly lagging behind the virus. So virus evolution is racing ahead of our ability to develop newer forms of the vaccine. And I talked about BA.5 bivalent vaccine. Well, by the time that vaccine came, the virus had already evolved from BA.5 into BQ 1.1 and XBB. And so we're constantly behind the virus. So And in terms of monoclonal antibodies, we're trying to generate new ones, as shown by the example I gave at the end of my presentation. So those are the strategies. Of course, there are now a number of drugs that target the protease and the polymerase of the virus, and those still work, and these variants have not evaded those small molecule drugs.
Thank you, Dr. Hook. The second question is, do you think the vaccinations could have led to the increased ability of SARS-CoV-2 to mutate that would not have been happened if this immune response pressure had not been there in the infected individuals?
Yeah, I think vaccination, allow us to increase the level of herd immunity in terms of antibody responses against the virus. So more and more people rapidly became antibody positive against the SARS-CoV-2 spike. And that certainly forced the virus to evolve faster. While that sounds negative, of course, we have to think of the positive aspect of vaccination, and that is it protected some of us from catching the virus, but more importantly, it prevented many of us from succumbing to severe infection or possibly death. So the vaccine really did its job, but it also increased the antibody pressure on the virus, forcing it to evolve in the way we have witnessed over the past 2 years.
Thank you, Dr. Hope. The second question is, let me see which one I took first in order. Given the high degree of variability and rapid evolution of SARS-CoV-2 variant with antibody evasion properties, what is the likelihood of developing a single vaccine or a therapeutic that is effective against all current and future variants? And what are the potential strategies for addressing this challenge? Loaded question.
Yeah, I think it's possible based on experimentations that have been done in animals. There have been a number of groups that develop vaccines that are multivalent and have started immunization with those multivalent vaccines. Some of them are spikes, but many of them are just the receptor binding domain, but from many different strains, not just different strains of SARS-CoV-2, but SARS-1, SARS-CoV-2 subvariants, and some of the so-called sorbicol viruses or viruses related to SARS-1 and SARS-2. And those strategies have generated a much broader antibody response that could protect against many different pathogens. But the problem now is we all have immunological memory to SARS-CoV-2, particularly the original strain, because that's the vaccine strain that most of us have seen. So the issue is immunological imprinting. It's the same issue that we have faced with influenza vaccines. We like to see what we've seen before. And so, for example, I've been vaccinated multiple times with the original strain. If you give me something that's multivalent, I would still preferentially see the original strain. And this is the challenge posed by immunological imprinting. But it is possible to come up with a broad vaccine.
Thank you very much.
Some more work done.
Thank you, Dr. Hope. Let me choose one. We are done with this one. Okay, we have a question here. So I'm going to read this long question, but anyway, let's try. How do the current vaccines for COVID-19, which target the spike protein of SARS-CoV-2, affect the interaction between the virus's spike protein and the cluster of differentiation proteins on the host cells? And what impact does this have on the efficacy and potential for preventing infections?
I haven't read anything that suggests there would be additional impact on other effects. So I'm not in a good position to answer that question.
Thank you very much. Okay. So then there is a question by, and it's addressed to you, Director. Said, dear Prof, you were mentioning bivalent vaccines have little or no beneficial in the studies you pointed. So what would be the current or the future vaccines in the event of more evasions of the strain? Will there be new promising and monoclonal antibodies shall prevail widely with the existing vaccines?
Yeah, so let me elaborate a little bit. I think I said the bivalent vaccine did not show superior results compared to the monovalent original vaccine. However, they did boost, as did the monovalent vaccine. So boosting helps, but we did not witness a superior boosting response from the BA.5 bivalent vaccine. Whether that pattern would, I mean, I only showed 2 data points at 1 month and 3 months. What would happen if one were to get a second bivalent boost? That we still don't know. So the entire picture is not clear yet, but the initial hope that we would see a better response immediately with the bivalent vaccine is not quite true. We could still think of strategies to anticipate virus evolution and to think about novel vaccine boosters, but we will still be challenged with the immunological imprinting issue. And that's why, it goes back to the earlier question about whether we could make vaccines differently, particularly multivalent vaccines, from the outset. And that, the immunological imprinting is a challenge for all of us who've seen the virus as a vaccine or the real virus already. But there will be youngsters coming along who have never seen anything, and we should think about how to vaccinate them best in the future.
Thank you, Dr. Hope. There's a very provocative question here. Why the target of scientists is directed towards developing anti-SARS-CoV-2 antibodies and vaccines in such a rapidly evolving virus? There will be high cost with short-term benefits.
Yes, I think in retrospect, that is the picture. Most of the antibodies were developed with millions and millions of dollars of investment, and then they were useful for a short period. But we did not know that then. And these companies now are holding back, even though some of them have new antibodies that will work. But, would it work only for a few months or a year and then be wiped out by new variants? And so there's a lot of concern whether new investment should be made to develop some of those clinically. And so, greater attention has shifted to discovering small molecule drugs that would target better conserved elements within the virus. But still, I think we have to think of millions of people who do not respond to vaccine. And many of them are really afraid. They're already immunocompromised typically, and so they would suffer from SARS-CoV-2 infection. And they, if we had a good antibody, they would benefit for however long they would benefit.
Thank you, Dr. Hope. Let me go. There's another question here. Can advanced language models such as machine learning algorithms and natural language processing techniques be used to aid in the development of vaccines and therapeutics for SARS-CoV-2 variants with antibody evasion properties? And what is the future? What is the current state of research in this field?
Yeah, I think that's really a great question looking ahead. It's something that we have considered. In fact, we had months of discussion with Google's AI team to see if they could take all the available data in the database, all the monoclonal and structural data, and all the variant data, and see if they could use artificial intelligence to guide us as to the direction of travel for SARS-CoV-2. But after months of discussion, it was deemed by them to be too difficult at the moment. But that doesn't mean that the field will give up. I think some of us will continue to try to engage AI experts to see if we could try to outsmart this virus.
Oh, sure. That would be great. Well, thank you, Dr. Ho. The second question is, are there any other parts of the SARS-CoV-2 virus besides the spike protein that could be targeted by vaccines and therapeutics to prevent or treat COVID-19? And what is the current understanding of their potential effectiveness and safety?
Yes, I've been talking largely about humoral immunity mediated by antibodies. Of course, there's a whole other limb of the immune system, cellular immunity, that undoubtedly is helping to protect against severe disease, even though cellular immunity up till now does not confer much protection against infection. But I'm not aware of anybody who's actively pursuing vaccine based on cell-mediated immunity, even though I think it could play a role. It's just not being worked on very much.
Great, thank you. Let me turn to some of the questions here. There's a question here. Given your long-standing experience with tackling HIV-1 infection in humans and now SARS-CoV-2, both RNA viruses with the ability to evolve in the face of mounting immune response, could you summarize how you have found the two viruses to be similar and yet different in their potentials to evolve and tackle the immune responses?
Yeah, both viruses have caused major pandemics. One did it slowly over a period of many decades, and the other one over a very short period of time. So the kinetics, the dynamics of the epidemic are totally different. And of course, one is casually transmitted, like SARS-CoV-2, and the other one is transmitted only with intimate sexual contact. So the transmission routes are very different. However, they share commonality in that they both evolve a great deal. So virus evolution, but interestingly, HIV evolution is largely occurring within one person over a period of years or decades. And one sees an evolution of a single virus evolving into a species, a quasi-species of viruses, all within that one individual. And then perhaps occasionally transmitting it to another person. SARS-CoV-2 is different in that it just bounces so quickly from one person to another, and then evolution is occurring with each transmission, with selective pressure within each host being different. So it's really fascinating to compare the evolution of these two pandemic viruses.
Thank you, Dr. Ho. I have a related question on this topic. Could you comment on how and why we have been able to develop a vaccine so quickly for SARS-CoV-2, but not for HIV-1, despite the fact that both these viruses mutate and evade the host immune response? Does it have to do something with the high rate of mutation in case of HIV-1 as opposed to in case of SARS-CoV-2?
Yeah, so we were able to, there are a number of answers to that question. One is we were able to develop a vaccine against the original strain of SARS-CoV-2 because for the first year and a half, the virus stayed pretty much as the original strain. And then we were only looking at homologous protection. And that's why the efficacy was 90%, right, with the mRNA vaccines. And now it's down to 30%. And a 30% vaccine is probably not acceptable. The other issue is actually the more important answer, and that is HIV has essentially a shield that protects the glycoprotein from neutralizing antibodies. And that shield is largely comprised of sugar, glycans, that decorate the surface of the spike. So only antibodies that are able to penetrate this glycan shield could get at HIV. That is not so much the case for SARS-CoV-2. And so strategies that work for SARS-CoV-2, when you apply it to HIV, simply do not work. So it's has to do largely with the fundamental difference in the virus structure.
Thank you very much, Dr. Ho. One question is, in the light of the limited efficacy of bivalent vaccines against SARS-CoV-2 variants with antibody evasion properties, what new vaccine strategies or treatment are being developed to address potential future variants, and how might monoclonal antibodies play a role in this effort?
Yeah, again, let me modify that statement a little bit. What I said is that the bivalent vaccine is not working any better than monovalent vaccines so far. However, both still boost. And as you boost, you not only expand the antibody levels, you also expand the antibody breadth to cover more variants. Even though some of the current variants are quite resistant, you still get a boost. So for the moment, that's all we have, and that's all we could do. So I was just expressing some disappointment that the bivalent did not perform better than the monovalent, but it doesn't mean it doesn't work. It still boosts, but not as well as we had hoped.
Thank you, Dr. Ho. I'm not sure there are plenty of questions here, but the time is a little short. I think we are towards the very closing of the thing. Would the organizers would like to continue with the quick Q&A, or should we stop it at here? I guess I can, while they decide, I can take one more question, I guess, here. Well, it is, I think it's a little bit, well, it's interest. Okay, so I have the marching orders to continue with. So there's a question here specifically about your antibodies. How is the human monoclonal antibody that you kindly displayed today, whether by 14-7 or 12-19, in the challenge of SARS-CoV-2 being evolving daily, and how effective are the human monoclonal antibodies in the treatment of COVID-19 today?
Yeah, I think 14-7 is targeting a region that is prone to mutation. So its utility may be short-lived, if I had to predict, in that's the region the virus has a great propensity to mutate. So it would not be on the top of my development list. On the other hand, 12-19, which targets a conserved area that has seen very few mutations in the millions of sequences in the database. So that region, I think that antibody in particular has a chance to stay active against future variants. And so if I were to push one forward, it would be that latter one.
Thank you, Dr. Ho. There's a question here, which I guess I should answer on behalf of you. It says, what are some of the key discoveries and contributions that Dr. David Ho has made to the fields of HIV and AIDS research? How have these impacted our understanding and treatment of the disease? I guess somebody joined it late, and I mentioned in my introduction to Dr. Ho's career. Dr. Ho has been instrumental in understanding the HIV replication, which led to the discovery of the antiretroviral therapy, through which he came up with a concept called HART, highly active antiretroviral therapy, which really has worked like a magic. People currently in the western part of the world, people do not die with HIV infection now anymore, because these have done wonderful job in curbing the virus replication in the body. And for that very fact, Dr. Ho was put on the front page of the Time magazine in 1996. And I hope that would suffice to say for now.
Thank you.
Okay, so let's see what we have. Okay. Well, I think this we sort of answer, but it's good to take up this question. How do SARS-CoV-2 variants with antibody evasion properties compare to other viral pathogens in terms of their potential to evade the host immune response, and what lessons can be learned from previous experience with similar viruses to guide future research and interventions?
Yeah, so the SARS-CoV-2 evasion of antibodies is very reminiscent of influenza evasion of existing antibodies. As the influenza strains drift or shift, the antigenic features change so much that prior antibodies no longer could neutralize that virus. And in many ways, it's the same thing in HIV, except in HIV occurs in a single individual. So you initially a person is infected with the one strain of HIV, he mounts antibodies against that strain, and then that forces the virus to evolve within that person to a different variant that evade the earlier antibodies. And then that second variant would elicit antibodies that would chase after the new variant, and then this game would go back and forth. That's how we see it in the HIV scenario, except with SARS-CoV-2, it's occurring within the population.
Thank you, Dr. Ho. So that is also quite provocative questions. So what is the prevalence and distribution of SARS-CoV-2 variants with antibody evasion properties across different regions and population? How do these factors influence the overall dynamics of the pandemic?
I think no matter where you look nowadays, all the dominant variants are very evasive to antibodies. So, for example, in Singapore, it would be XBB. In the US, it would be XBB, BQ, and CH1. But they are all quite resistant to antibodies. So that is the dominant selection feature. Now, of course, antibody levels within different population would differ. And that's why we're not seeing the identical picture in every geographical region.
Thank you, Dr. Ho. And I guess I think this will be the last questions. I think I will take it. As you mentioned, mRNA-based vaccines and nano-coated vaccines is more effective than the vector-based or inactivated virus-based vaccines, like Indian vaccine, like Covaxin or Covishield. My question is, for upcoming threat, mRNA-based vaccines or nanoparticles could be coated our future of the vaccine industry.
Yeah, I think those are the most potent vaccine strategies we have today. And I think for those who have gotten to sort of the weaker vaccine, a boost of the mRNA or the particle vaccine will go a long way in helping. But this also tells us in the future how we should prioritize some of the vaccine platforms. And clearly mRNA and nanoparticles are on the top of the list.
Okay, before we conclude, I have a question for you. I'm sure you came across a paper in PNA some time ago in which they have said that the RNA could reverse transcribe after giving up mRNA-based vaccine, and perhaps that could integrate into the host chromosomes. Do you want to talk about it a little bit, if possible?
Well, now this mRNA vaccine has been given to more people than we know of for any other vaccine platform. There's been no serious consequence to speak of at any high frequency. So I think the benefits clearly outweigh the risk, and then this reverse transcription idea I don't think is believed by too many people.
Thank you, Dr. Ho. I think that will end the quick Q&A sessions, and I have now closed the session. So I would like to thank, on behalf of the Sheikh Hamdan bin Rashid Al Maktoum Award for Medical Sciences, I would like to thank you, Dr. Ho, for taking the time out to talk to us today, and I hope we will have many more interactions in the years to come.
Thank you.
Before I close, there are a couple of business announcements. All attendees will receive an email to download the CME certificate within the coming days. We would also like to take this opportunity to announce the next speaker for this webinar series, and that will be Dr. Ian Fraser from Australia. Dr. Fraser is the winner of the Grand Hamdan International Award and will talk about his work on the development of HPV vaccine. Thank you all for joining us, and this brings an end for today's webinar. Thank you, Dr. Ho, again.